All right, welcome back. We are heading into, week 7, where we will be talking about chapter 6, which focuses on behavioral health. I know this is an area where a lot of you have communicated your interest, and so we will try to break this field down as much as we can. I do think this is one of the chapters where the textbook does a pretty detailed job talking about the history of the field, as well as some of the big things that you might expect to see working in a behavioral health setting. So I will mostly just be speaking on some things that I think are important, but I think there's a lot of good material for you to review here. I am not going to go through specific diagnoses because I think that while that is really interesting, and I imagine a lot of you would be interested to learn about that, I think we could get really bogged down in that and spend way too much time talking about that. And we're definitely not here to review the DSM. So we will save that for another class that I'm sure many of you will take. The place I wanted to start with this micro lecture is acknowledging that the history of this part of the field is really rough. The book touches on deinstitutionalization and what early versions of mental health care looked like. And I just really want us to make sure that we're sitting with that and that we're holding on to that, because the field still carries that history. And when we're looking at what it means to people to be hospitalized for mental health, I personally don't feel that we can practice responsibly if we are forgetting where we came from. Early mental health care was not good, just to put it very simply. And I think in my personal opinion, did a lot of harm. And I hope that we are doing this better now. But again, I have not worked in an inpatient psychiatric setting, which is part of what we're talking about here. But having worked in community mental health, I can say that things do look very different. But again, this is not a well-resourced field, and this is a field where people are really vulnerable and there is a lot of potential for harm. So not to be a complete downer, but I do want us to think really critically about this work and the history of this part of the field. So that was the first thing I wanted to talk about. The rest of what I want to touch on is much more bland, I'll say. So the first thing I just want to touch on is making sure we're breaking down what different levels of care look like in mental health, because just like with every other chapter that we've talked about, this is not just one thing. You can work in mental health in the outpatient setting where you're doing counseling or running groups or providing support to people while they go about their everyday lives. There is also sort of a tier level of higher level care that can be accessed by people who are having kind of increasing levels of mental health symptoms that are disrupting their daily lives. When we think about when we're diagnosing, when we're prescribing medications, when we are really intervening in people's lives for mental health reasons, what we are really looking for is whether these symptoms and these diagnoses are impacting their ability to live the rest of their lives. If you do decide that you want to go out and review the DSM or the Diagnostic and Statistical Manual of Mental Disorders, again, you don't have to do that for this class, but feel free if that's something that sounds like a good time. Something you will see again and again and again is whether the diagnosis impacts the person's daily life. Because if it does, that's when we're starting to see these things become really disruptive. So, aside from just counseling out in the field, or working as a case manager or a therapist kind of in a community mental health or a private practice setting, the next tier that you would see would be what we'd call intensive outpatient, which is exactly what it sounds like. It's still outpatient. People are still living in their homes. They can still go do the other things they need to do, but they are getting a lot of therapy. This can be individual, this can be in groups. Often, at least in what I've seen in the pediatric setting, this is sort of a mix of modalities. So it's very common for people to have individual sessions, family sessions, group, the whole shebang. The tier after that is what we would call a PHP, or a partial hospitalization program. Again, these people are able to stay in their homes. They're not staying in the hospital overnight, but they are there a lot. They're there all day. They are doing even more therapy than the first time around. And there may be some additional management of medications, or just additional oversight built in to that longer day. And then above that, we do have inpatient psychiatric care, which I think is what a lot of people likely think about is either counseling or inpatient care, and there are some areas in between. When we're talking about inpatient care, oftentimes, I think what a lot of people think about is involuntary inpatient care. There is also voluntary inpatient care, especially for adults, where, you do have to meet a much higher level of need, but you can theoretically, you'll hear people say they sign themselves in to a facility. So that's sort of the top tier of mental health care. To my knowledge, there's nothing above that, unless I'm just completely spacing on something. But being hospitalized all the time for mental health, especially against your will, is pretty much as restrictive as it can get. When we are thinking about inpatient, again, there are plenty of times when people make the choice themselves to enter into a more restrictive care environment. But there are also plenty of times where people are there for reasons that are kind of imposed by the system. So when we think about people being hospitalized against their will, what we're likely thinking about is the Involuntary Treatment Act, which basically says that if someone is deemed to be a harm to themselves, a harm to others, a harm to property, or unable to safely care for themselves because of a mental disease or defect, the people assessing them can essentially go to court, say that, and a judge can decide, okay, yes, you are not well, you need to be hospitalized. There is a lot more that goes into that. I worked in mental health court very, very briefly, which is not the same as ITA court, which is where you would see all of this happening. But in working in that system, I am vaguely aware of how this works and have had to almost write an affidavit in my own work since then due to concerns of this nature. So essentially what happens when you are worried, you as a professional, I imagine you could even do this just as a lay person, but I think you're probably unlikely to do it as a lay person, is you basically write an affidavit. If I can include a copy of what that looks like, if anyone's interested in that, I will do that. But it's basically just a statement that explains why you're concerned, who you're concerned about, what you've seen that has raised your concern to this level, and that gets submitted to a group called the Designated Crisis Responders. Again, kind of what they sound like. That is their job to then go out, assess, and make a decision about, in this moment when I am seeing this person, are they safe, to others, to themselves, to property? Can they care for themselves? Are they safe to keep living out in society, basically? Or do they need to be hospitalized against their will? So it's actually a much, much longer, much more involved process than just calling 911, an ambulance comes to get someone and takes them away. And as you might be able to imagine, if you've worked with people who are severely mentally ill before, sometimes these crises, these symptoms kind of wax and wane. So you may be really concerned about someone when you meet with them, but then by the time you write your affidavit, the DCRs come out, that crisis might have passed and they might be presenting a lot differently. So this is also not a foolproof system. We don't always see the full level of concern at each stage of this process. The last thing I wanted to touch on, kind of on the flip side of that very kind of dramatic part of this work, is what this work really looks like in the day to day. The main things that you are going to be seeing if you work as just a general counselor, again, in an agency or in private practice, aside from if you are doing really specialized work, maybe you're really trained in DBT and so you're just doing DBT, or you're doing any kind of trauma services and you're just doing trauma, you are really just going to see a lot of people dealing with life. You will see a lot of anxiety, a lot of depression. You might see some personality disorders, but as we won't talk about in this course, but as you might talk about in some of your other courses, those are diagnoses that don't necessarily respond to therapy the same way that things like anxiety and depression do. And so you're less likely to really see those cases through as just kind of a general mental health counselor. And again, really what you're going to be dealing with more often than not is just helping people fit better into their own lives in the context of the symptoms they're experiencing. And I think some people really enjoy that, but it's something worth knowing if you're considering going into this part of the field, if you are wanting to be doing this really high crisis, responding to these really, really mentally ill folks. That is a very specific and small part of this field. So, a few things to consider. Please do read as much of the chapter as you can. I know this one gets a little dense when we're talking about some of the disorders and medications and things like that. So please don't stress yourself out too much, but let me know if you have questions. If, again, because I know there are a lot of people who are really interested in this part of the field, please do feel free to post those questions in the discussion board. I will see if I can get answers to them for you. I make no promises, but I will do my best, and I will let you get on with it.